Hi, I'm Dr. Aliabadi. If you struggle with irregular cycles, acne, facial hair, body hair, hair loss, or insulin resistance, you might be dealing with PCOS or polycystic ovarian syndrome. Having dedicated my life to helping women with PCOS, I understand the challenges in getting an accurate diagnosis and the right care. That's why I created Ovii, a science-backed alternative to prescription medications. Ovii is designed to help you take control of your health with clinically proven, validated ingredients in a simple, once-a-day solution. For too long, women with PCOS have had to choose between lifelong prescriptions or complicated supplement regimens. Ovii offers a better way to help manage your symptoms without the hassle. It's my mission to empower women facing PCOS and other hormonal issues by providing the information and support they need. Reclaim your health once and for all. Go to ovii.com. That's ovii.com and start today.
So on today's episode, we have the amazing Kelly Casperson, and she has one of my favorite podcasts, and I love the name. It's called You Are Not Broken, and we're going to dig into how that started. You were trained as a urologist.
Yep, I'm a urologist.
And then quickly became an expert in sex, and I just kind of want to know how you've had so many twists and turns, and we love to talk about women and how we climb one mountain and then we climb another mountain and then we climb another mountain, and you've been doing that all in your career. So can you tell us a little bit about how that all started?
Yeah, absolutely. Thanks for having me. So I was a urologist, private practice, built the business, built the surgery center, did all the traditional great things. And when I was in residency, an attending told me, watch out for the 7-year itch. He's like, watch out if it's your marriage, if it's your career. At 7 years, something happens. And so I had that in the back of my head. And right around 7 years, I'm like, oh my God, I'm bored. Like, you train your whole life to do this thing, and then you're like, am I just going to see recurrent urinary tract infections for the rest of my career? Like, is this it? I'm going to say the exact same thing over and over again. And then I was like, okay, I don't know what to do, but this is what the 7-year itch is. And I think, truthfully, the universe was like, okay, she's ready, right? And so what had happened was a patient of mine came in. I had treated her, cured her from bladder cancer, was very bonded. So, I had a connection. And she was crying in my office because of sexless marriage and feeling so broken and didn't know what to do. And I'm handing her the box of Kleenex, and the lightning strikes my brain of you don't know how to help her. And everything that I had been taught came back hey, don't worry, the gynecologists are taking care of the women. Women are complicated. They take too long in the office. We don't want to deal with them anyways, and we'll never figure them out. Those are all things that I was told in residency. And so I just started digging of is that true? Is it true? I learned everything about female sexuality. I did that for about a year. And then the voice in my head was you need to talk. You can't know all of this with how much need there is. 5 years ago, I was no urologist had a podcast at that time. I was I'll probably get kicked out of the urology club, right? All these doubts. I was waiting for somebody to tell me I knew enough. And I was getting out of the shower one day. And again, lightning struck my brain and was oh, it's your permission that you need to give yourself. Nobody's coming. So started the podcast. And then I joked that I got into menopause and hormones because of sex. Because as I started talking more and more about female sexuality, people are yeah, but you know what's going to happen with menopause and sex and your sex life. And so I just really started to dig deep on hormones and be holy crap, hormones are fantastic for you. And we're afraid of them. Right. So really started to kind of get vocal on menopause, perimenopause, postmenopause. So really I'm the Venn diagram of sex ed, hormones, and testosterone, and me are sitting in the middle. That's the story.
I have to tell you something because it's related to urology and the training. When I was in medical school, and this is the truth, a couple of years before I started my 3rd year of rotation, so you do 2 years of, in classroom and then 2 years of rotations. Prior to the year that I started my urology rotations, women in my medical school were not allowed into the urology rotation because urology was for men. Well, then I ended up going to OBGYN and, but as a urology rotation, they would not even allow women to rotate through a
Wow.
and it's so rare for people who don't know this. Majority of urologists are men, and it's not common to have a women urologist, let alone a woman urologist who's a woman's advocate.
Yeah.
So that's very rare, and that's
it's
why
super rare.
it's super rare. So that's why it's so amazing. For a
That's
woman
wild.
to be a urologist is just incredible. Lucky for all the patients who get a chance to see you and to get so educated about it. Thank you. We need more doctors like you on this planet.
There's about 1,000 female urologists in America now, so not a lot. When I was in medical school, there was one female urologist in the entire state.
You see?
I never met her.
You see?
I have to say, I think about our poor mothers who really were just terrified of hormones. My mother did not, because they were told that it was going to kill them and they were going to get cancer and all those things. And I remember when my mom went through menopause, and you could tell she was suffering and all the things. And now, I'm at this place in my life that I'm perimenopause. And I'm so blessed that I have this woman next to me that was like, we're going to slap on a patch on you and we'll see what happens there. But what do you think you've learned the most from having your podcast that was different than you knew in being a medical doctor in a room with a patient?
Yeah, that's a really good question. So I think that all doctors think they're doing a good job. We show up, we take care of our patients, we go home. And then me getting on Instagram and social media, the world started talking to me and being like, I'm on my third doctor, I'm on my fourth doctor. My doctor told me this. And like, oh, doctors say crappy things to women, by the way. And I don't blame them. The system, 10-minute visits, seeing 27 people a day, that's not healthcare, right? You can't get your perimenopause and menopause addressed in 10 minutes once a year. Mm-hmm. These people are suffering greatly. And there's that huge disconnect. So that was my one takeaway. The second takeaway is like understanding my role as a medical translator and how that's what research has completely neglected to do. We're always like, we need more research. And we're like, but it takes 17 years for good data. It's a JAMA article. It takes 17 years for good research data to actually get into the clinic.
Right.
And it's that translational piece we're completely missing, which is what podcasts do, doctors on Instagram do, is like, we are translating the data and how it applies to you,
right?
As far as like, the pillars of academia of like research, teaching, translation.
Well, that's such a great thing to say, because that's why we started the podcast. I listened to all the medical podcasts, and at one point my sister, who had actually met you at a conference, said, "You've got to get her on the podcast.
Yeah, I know.
She's amazing."
I remember.
Yeah. And she said, you've got to do something with these, like, listening to these podcasts. But they were also male focused. And even some of the great ones that I love, it was like every now and then you got a little sliver of something about female health. So, that was what was amazing to actually find your podcast too. So this is something that I hear a lot from my friends. And when you hit perimenopause and menopause, I mean, there's several reasons. Sometimes it's because you've been with your partner for a really long time and the oomph and that's kind of not there. Sometimes it's because you have vaginal dryness now for the first time, and so it's painful. Sometimes you're just pissed off because you're in the middle of menopause and you want to kill everybody around you. So, I mean, these are the different things that I see. But I guess let's start with you. If you have a patient that comes in at any point, what do you do with them when they say, I don't want to have sex with my husband anymore?
If we're talking about sexual intercourse, it's not just issues with menopause. At any age, women can have issues with sex, right? When you're younger, for example, if you have endometriosis, if you have imperforated hymen, if you have infections, PID, and the list goes on and on, you can have painful fibroids, you can have painful sex. As you get older, these things changes, hormonal changes, anxiety, depression, PTSD, all of it can affect your sexual experience. At menopause, as you said, your libido goes down because of the hormones going down. Our estrogen goes down, we get vaginal dryness, our testosterone's down, sex becomes more painful, you're more anxious, you don't feel good about yourself. So it's a combination of things that will affect it. And unfortunately, until these podcasts started talking about it And physicians like you who started talking about it on social media, most women would go to the physician's office and they would be too shy to bring it up. And especially if your doctor is a male physician, I would feel uncomfortable talking about my sexual life to a male gynecologist. So more and more women are, going through these OBGYN residencies, and we have doctors like herself who are openly talking about this and helping women. So hopefully together we can change this.
But it is the overreaching theme is like, if you were lucky, you had an amazing mom who told you some things, but otherwise you got a disease and pregnancy prevention plan, right? So we did not get adult sex ed, but because we don't get a baseline of adult sex education, we feel super broken. And that's like where the name of the podcast, You Are Not Broken, came from. Because women just kept saying over and over, like, I'm so broken. I don't have an orgasm by putting, a penis in my vagina. And I'm like, oh, 70% of women don't. Like, once
70?
you know the data,
Mm-hmm.
yeah. Once you know the data, you just tell them the data and then they don't feel broken. And I'm like, no, you have to involve the clitoris. Like, you're having sex that preferentially gives somebody else an orgasm. We got to switch that up. Right. And then, another woman will come in and she'll be like, I've never had an orgasm in my life. And I'll be like, well, you're not broken. 10% of women haven't. Usually not because their body is broken, but because we were shamed. You're not allowed to touch yourself. Nobody's ever taught how to have an orgasm. Like, it's not a personality flaw. Like, we just didn't get adult sex ed. And so that's the overriding theme. I mean, same with menopause. If people think menopause is the end of periods and a hot flash, they have no idea that their pain with sex is because of low hormones. Like, they have no idea estrogen actually like goes all over the body, right? So a lot of this is lack of education.
And I want to add, I come from Iran. It's a Middle Eastern country. Growing up in Iran, and I don't come from a religious traditional family at all, but spending time with my friends from a very young age, they're like, close your legs, don't talk about this. You're not allowed to have sex until marriage. You're not allowed to talk about it. Nobody ever talks to you. Your parents don't talk to you. You don't even know what a period is. Most girls start bleeding not knowing what happened to them. So especially when you go to those cultures, there is zero information and education about these topics.
I mean, I grew up in the South. Like, I was ashamed to tell my mom I had got my period. The message that we got was always like, no sex before marriage.
Right.
So it's this shame that kind of came around. You were taught that this isn't a beautiful thing. So can I, from a patient perspective, can I ask you guys a few questions that I think a lot of women want to know? How do you find your clitoris?
Mirror.
Okay. So what do you do? So
I think people know where their clitoris is.
I'm telling you,
they don't.
You would be shocked. So you stick a mirror
down and
Okay.
just start, you don't need to label everything all of a sudden, right? You can just be like, let's look at it. What's it look like? And just like start just knowing it. You don't even have to label it. Just be like, this is my body.
Yeah.
I'm getting familiar with my body. OMG Yes is a great website as far as like learning how to orgasm.
Oh, okay.
Sex for One. It's an old book, but really good for like learning how to have an orgasm. Good drawings in there for things.
So I have another question for y'all that I know a lot of women my age are wondering. When you think about estrogen, does the patch help the painful sex and the lubrication, or does it have to be estrogen for the, like the cream on your vagina? And can you take both?
Great question. Different words for it. Vaginal estrogen, pelvic estrogen, low dose estrogen. It's really hard to say vagina on Instagram without getting blocked. That's why podcasts are amazing, because we can actually say body parts.
Vagina.
Podcasts, the last bastion of anatomy. So vaginal estrogen is what a lot of people call it. And so it's incredibly low dose, meaning it won't be measurable above postmenopausal levels if you draw your blood after being on it. So very low dose, it's just skincare for down there.
Okay.
I always like to play with a math equation of like, okay, so if your estrogen patch gives you X and your vaginal estrogen gives you 0, X plus 0 is still X, right? Because people are like, oh, my doctor said I can't be on both. And I'm like, well, the vaginal estrogen is not adding any hormones to your body. So it makes no sense that somebody says you can't be on both. And the other question is, well, is the patch enough? For some people, it's enough. hormone therapy is still very low dose. This is still like getting you above postmenopausal levels, but not where you were when you were 28. But many people, not well studied, but probably 30 to 50% of people are on both.
On both.
Yes, and I want to add, even for patients with breast cancer like myself, with when you're getting treated for breast cancer, or when they put you on these anti-estrogen systemic therapies to block the recurrence of your breast cancer, you are still allowed to take vaginal estrogen. But there's so much misinformation. Patients think if they put estrogen in the vagina, it'll get absorbed and it'll increase their lifetime risk of breast cancer. So it doesn't. It's minimal amount of it can be absorbed, but not enough to affect anything. So even with breast cancer patients with vaginal dryness, they're allowed to use vaginal estrogen. I also want to say there are CO2 lasers available for vaginal dryness, especially at menopause, that I have really, really good results with. Basically, it brings elasticity, vascularity, flow to the vagina. So if you're sexually active, if you use your vaginal estrogen, if you need to, you can also be on the systemic hormones. And in cases where patients are not feeling better, there's hyaluronic acid in the vagina, vitamin E I love. So there's a lot of combinations we can use for different patients, and not all patients are treated exactly the same. Like she said, there's some patients who use systemic hormones and they have no vaginal dryness. And there are other patients who use it and they still need the vaginal estrogen. So that's when your gynecologist will decide what treatments, you would need.
And with vaginal dryness, is it just something that happens during menopause and then you can get lubrication back, or do you have vaginal dryness for the rest of your life?
The rest of your life. I mean, and that's, again, menopause is low hormones. So once your period's end and your hot flashes end, you're not getting more hormones.
Right.
And it's the low hormones that causes the vaginal dryness. And a lot of people, it will start happening in perimenopause. Also, you'll see it with breastfeeding. You'll see it with oral birth control pills. You'll see it with some cancer therapies. So there's a lot of things that can affect the hormones of the pelvis. It's not just postmenopause, but very commonly you'll start seeing people be affected 7 years postmenopause, 8 years postmenopause, because it's just a cumulative low hormones. And then their minds are blown because they're like, menopause was 7 years ago. They're like, yeah, you've had no hormones in your pelvis for 7 years. It's finally starting to bother you.
And you can start 7 years before you go through menopause with vaginal dryness. So, premenopause can start 7 to 10 years before menopause. So if you have vaginal dryness, you can absolutely treat it. You don't have to wait not to have a period for a year to start treating the vaginal dryness.
That's a big myth that I see, that I hear women say a lot. My doctor said I can't have vaginal estrogen because I'm still having periods.
I had a patient at age 44 or 45. She was complaining of all these symptoms of menopause. And her doctor says, I don't want to talk about it because you're not in menopause yet. It's like, what?
Yeah.
Yes, you are.
So do you guys recommend lubrication for sex if you're
Always.
Okay, always.
Listen, this is what I tell people. The penis is not self-lubricating. The clitoris is not self-lubricating. Why are you making the vagina do all the work?
Exactly.
Unequal distribution of labor. Get some lube on everything.
And what lube do you like?
I like silicone-based lube, and I like oil-based lube. Caution oil-based if you're using condoms, because they're just longer lasting. And especially with that drier menopausal skin, water-based, you'll just suck up all the moisture because you got such dry skin. They're not that sticky tacky that you can get with some water-based ones. So I just like it. I like oil-based because it's more like body temperature. It's not cold when it goes on.
Can you give us
I'm
3 names for our listeners? And we're not marketing for these people, so
yeah. Uberlube's really nice. That's a silicone one that's really nice. Naomi Watts' skincare line for postmenopause called Stripe. They actually make a play oil that's oil based called Oh My Glide. It's lovely. But if you have a good sex store in your town, I have a nice sex store in my town. We actually have a wall of lube, and you can try samples and stuff like that. Lube is not expensive stuff, so it's okay.
One thing that I've also noticed for myself, and I tried for my patients, vitamin E, I compounded for my patients. And basically, if you use it twice a week, it somehow stays in the vagina. And during sex, you can still use your lubrication externally, but internally it makes a huge difference.
And then another thing I wanted to ask y'all, testosterone, because I have some friends that are on so much testosterone, they're growing a beard. I'm like, you got to cut back on the testosterone. So
I will let her answer. That's
it's-
her.
It's super
specialty.
funny because with hormones, there's this mentality that like more is better. And I'm like, we don't do that with insulin. We don't do that with thyroid.
that was
You know?
me. And she's like, okay, we got to talk about this. More is not more.
This woman had 4 or 5 patches of estrogen on her skin when she came to my office. And as she was not feeling better, she would add another one. And then she didn't feel better, she would add another one. I'm like, what are you
don't do that.
doing?
Like there isn't a more is more for most medications. Most of my patients are pretty darn educated at this point because they listen to my podcast, they've read my book. So like I have the immense privilege of people coming to me being like, I know all the things, I'm ready, which is like, as a physician, it's a super fun place to be in, right? Because like I don't have to convince them like testosterone's a female hormone. Females make 4 times the amount of testosterone than estrogen, just 10 times less than men. Right? Most women don't know that testosterone's a female hormone, right? So it's like you got to step back. Otherwise, people are like, they think you're crazy for wanting to give them something that they don't know their body ever made.
And what about like blood tests for hormones? Can you kind of explain that a bit?
So I always tell people, we can get labs. Like there's no harm in getting labs. Just don't think that it's a fixed state, right? And like what's happening Tuesday in January is going to be different than Thursday in February. And the opposite is true for postmenopause. I get a woman who comes in and she's like 6 years, she hasn't had a period. She's 62. She's like, can we check my labs? And I'm like, well, if you want to, like, but they'll be 0, right? Like I already know what your labs are going to be too. And this is what I'd say, my advice for doctors is like so many women, they just want the validation. Like checking labs makes them feel validated that their symptoms are real. Now it's on you to help them interpret that. To see that, it helps them validate that something is real.
I just also want to add that generally speaking, we treat symptoms, not blood levels when it comes to menopause. First of all, not all labs know how to do exact testosterone testing. Number 2, there are patients whose testosterone levels are low, but they're not complaining of decreased libido. They have no other complaints. Their body mass, muscle mass, everything's fine. Generally speaking, though, having gone through menopause, having had thousands of patients who've gone through menopause will decrease your libido. Almost everyone complains about it, and testosterone will make a huge difference for them. A lot of patients, again, have complained of hot flashes, brain fog, all these vaginal dryness, weight gain, painful sex, lack of sleep, anxiety, and the list goes on and on. And you can address that. Some patients would want to take hormones, some patients would not. Again, this is something you don't chase after labs. You listen to your patients and you treat their symptoms. For example, hair loss. It might not be, you might not have hair loss. I've been on minoxidil for 5 years. So again, you listen to your patients and you try to address their symptoms rather than chasing after a blood test. I want to go back to you since you're our testosterone expert. Talk to us about different forms of testosterone and what dosage and what do you prefer?
And what are the symptoms that show that you need testosterone?
Yeah, good questions. So in America, we do not have an FDA-approved testosterone product for women. It's coming. I know it's coming down the pipeline. But at this moment, and that's what makes it very challenging. The second thing that makes testosterone challenging is because of the 1991 Anti-Doping Act enacted by Congress after the Olympic doping scandals of the 80s, testosterone is a Scheduled III medication by the DHEA or by the DEA. Why is that important? You have to see your doctor twice a year. It's much more scheduled. In California, your name goes on a list of people receiving restricted medications. So that's a privacy issue for some people. So testosterone has a lot of barriers. So that's the first big mouthful to be like, why are there all these different options, but it's hard to get and insurance doesn't cover it? It's because we don't have an FDA-approved dose for women. Standard dose for women is about 1/10 the dose of a man. So if you take a male transdermal product, that's a 50 milligram dose. That means women will start with it. If you're going to do a transdermal product, you're going to use 1/10 of that. So 5 milligrams a day. I compound it because one pump of a compounded 5 milligrams, easy peasy, about $60. So that's why I've kind of gone away from, even though it's inexpensive, using a male gel product, is because it's just another hurdle of like, how do you microdose a ketchup packet? So I tend to do transdermal once a day cream starting at 5 milligrams. The data does go up to 10 milligrams in several studies. Pellets are pretty popular. The reason being, we don't have an appropriately dosed FDA-approved product.
I have to
So-
say, I absolutely hate pellets. I think the testosterone compounded creams work so well.
I
I've
agree.
seen the problem with pellets are, first of all, their testosterone levels go sky high suddenly. The hair loss that I see with it is massive.
It shocks the system.
It shocks the system. You cannot take it out. It's not FDA approved, as you said. But so I think that for me, in my opinion, the compounded creams, I have my patients put it in their inner thigh. Where do you have them do
Yeah,
it?
same.
Inner thigh. And they do it daily. It's compounded. Like she said, it's not very expensive. I think that would be a great start.
It's a nice steady state, and it's hard to go too high. The other problems with pellets are that's the most expensive option.
Yeah.
And if we're lucky, we're planning on 40 years post-menopause here. Do we want a little incision in our butt times 40 years as the most expensive option? So I don't have any data, but in my experience, women will try pellets because their friends tried pellets, but nobody stays on pellets long term. They always end up switching to something else.
So what are the symptoms where you should think about testosterone?
It's very vague, right? It's not like a broken bone and you need a bone fixed. But symptoms would be low libido. But remember, libido is very complicated. So testosterone doesn't work for everybody's low libido. Fatigue, low energy, not feeling like myself, which is very hard to measure in medical studies, but I would say is one of the most important things we can help women with is feeling more like themselves. I hear that all the time with testosterone because it's a brain hormone, right? Women will say like, my brain feels kind of slow. I'm working really hard at the gym and not seeing gains. Things like that. And the guidelines for testosterone do recommend checking a baseline testosterone. I'm still looking for that mythical perimenopause woman with high testosterone. I have yet to find her, but I check everybody's labs to follow the guidelines just to make sure you're not giving it to somebody with high testosterone. That might be a PCOS patient. And with the labs, like you were saying, you have to get the mass spectrometry lab, which in Quest Labs is male/female/child hormone, because the immunoassays are worthless for values less than 100. And if you get that lab, the reference range will say that normal is down to like 2. That's not a normal testosterone for a woman. So you really do need an expert who can interpret the labs, because so many women come to me and they're like, my doctor said my testosterone was normal. And I'm like, what was it? And they're like, 4. And I'm like, yeah, that's not a normal testosterone, even though the lab says it's normal.
And I would again say treat the symptoms of the patient.
Exactly.
If you're treating them once a day and they feel great and their libido's back and they have no complaints, you don't need to go up.
Right.
But if they're still complaining of decreased libido, having said that, libido has a lot of aspects. If you're anxious, if you're depressed, if you're having issues in your life, do you know what I'm saying? Other things can affect your libido.
And how do you know if your estrogen or your progesterone is too high or too low?
Again, you treat the symptoms.
You talk to the patient.
Yes.
Yeah, I mean, there's so many people, especially on like Instagram and stuff like that. People are like, give me a number, blah, blah, blah. And then they'll be like, what's your dose? Like, because they'll want to compare to people.
Yeah.
And I'm like, listen, I don't ask you what your weight is because that's the right weight for me.
Right.
Right? Like,
Right.
everybody's an individual, and it really does require a conversation of what's bothering you. But we all we want to compare and we want to get the absolute right thing. And it's like, that's not how it works.
Let me ask you a question. So we covered testosterone treatment dosages. Let's talk about vaginal estrogen treatment for postmenopausal women and all the different options. Can you go down the list and tell us what you prefer, which medication, what dose, how often, and then we'll go from there.
Yep. So multiple options just to give you the menu, and then we'll narrow it down on what I like. But the bread and butter is vaginal estrogen. You can dose that via a ring, a tab, a cream. Then there's intravaginal DHEA. The FDA-approved product is called Prasterone or Intrarosa. It's chef's kiss for beautiful vulvas. It converts into estrogen and testosterone. I love it. The problem is it's pricey. Then you can compound estrogen and testosterone creams, which is getting very nichey. into the more kind of vulvodynia pelvic pain world. Usually we don't do it unless you're coming with orgasmic dysfunction, arousal dysfunction, more specific sexual dysfunctions. We're going to add some testosterone down there. I always tell people I have a cream bias. Not everybody likes it, but this is why I like it. Number one, you can put it on your labia to prevent labial resorption. You can get it on your clitoris to prevent clitoral phimosis. You can't do that with a tab, right?
Will you explain what those two are?
So one is a form of a cream and one is a form of tablet. The cream is literally you have an applicator, you fill up the applicator with the cream, and then you insert it in the vagina. You can take some of that cream, as she's explaining, and rub it outside on the labia and on the clitoral hood. The pill, which is usually called Vagifem, it's a tablet that when you first start, you can do it every night for 10 nights, and then you go to twice a week. You can do the same with estrogen cream. When you first start, you can do it for every night for 10 days and then go to twice a week. I personally love the cream too. The problem with the cream is sometimes it leaks out of the vagina and not all of it gets absorbed. So you might have
I just tell people to use less.
Use less, or you can use a panty liner. It works really, really well. A lot of patients prefer the pill because nothing comes out, but then you don't have the benefit of having.
Then you don't have a little bit of
use.
cream to put up here by your eyes.
Exactly.
And the other form is the ring that, there's the S ring that you can put inside the vagina. What do you think of that? It stays there for 90 days. Yeah. And
Yeah,
then you
I
change
love it. It's plug and play. It's great for patients who maybe can't remember to do a twice a week application with the cream. A lot of people have mobility hand issues, so they can just go to the doctor, get it swapped out every 3 months. The biggest problem with it is cost. It's several $100s. Cash, I think it's still $400 or $500. But remember, vaginal estrogen decreases recurrent urinary tract infections by 50 to 60%.
What?
So yes. There's nothing better. There is nothing better to decrease urinary tract infections than vaginal estrogen. And we can talk about why. But so I tell people, I'm like, even if it's expensive, if it prevents one UTI, it's paid for itself.
Yeah. One of the symptoms that I got that I finally went and checked, to see if I was in perimenopause was having to pee all the time. And I'd never heard of that as a symptom. Remember I asked you, I was like, I'm peeing all the time.
So as we get closer to menopause, why am I saying this? We have a urologist. Tell them about urge incontinence.
You go.
No. I have the expert here. I'll let you do it.
Genital urinary syndrome of menopause is a mouthful. GSM is the abbreviation. Used to be called vaginal atrophy, but that didn't include the bladder symptoms. Before vaginal atrophy, it was actually called senile vagina in the 80s.
I have a senile vagina.
Senile vagina. So that's awful. So genital urinary syndrome of menopause is bladder, female genitalia, vagina, recurrent UTIs. All the changes, because again, estrogen's in every cell in our body until it's not. And then tissues start changing. So urinary frequency, urgency, getting up at night is a huge bother. Vaginal estrogen works like a charm for that. Recurrent urinary tract infections, not all types of bladder leakage, but bladder leakage can get better. The bladder muscle it's called the detrusor muscle. It's got estrogen receptors all over it. The interesting thing is anticholinergics are the classic overactive bladder medication that doctors know about. They're nasty medications. They're associated with dementia and falling, but they're cheap and generic. There's a whole bunch of them. Vaginal estrogen is equivalent in efficacy to anticholinergics without any of the nasty anticholinergic side effects. The problem is those papers are in menopause journals. Besides me, not many urologists are reading the menopause journals. But that's incredibly wonderful medication to use instead of an anticholinergic for overactive bladder.
And I think that's why a lot of menopausal women, after sex, they constantly get bladder infections. They end up with recurrent infection. They end up in a urologist's office. And in reality, it's always vaginal dryness. So even if you have recurrent UTIs and you go to a urologist, 9 out of 10, you're going to leave with a vaginal estrogen. So you might as well, if you have recurrent bladder infections, and you don't have symptoms of vaginal dryness, try vaginal estrogen before you show up to your urologist, because that's probably what you're going to, get going to that visit.
I have two last questions. One is, my husband sat me down the other day and said, Mary Alice, you don't remember a single thing that we talk about. He's like, I'm very worried about you. Like you you just forget everything. But I don't think enough people know that brain fog is a thing. And does it go away? Like after menopause, do you get your brain back? I guess that's my question.
Most people get their brains back. Some people don't get their brains back. To the current knowledge, people don't think brain fog is associated with dementia. That's the good news. The bad news is women are dropping out of the workforce at a significant rate because of untreated menopause, brain fog being one of the big reasons why, right? Like you just feel like you're not functioning. So it is a legitimate problem that I think is significantly dismissed by the medical community. This is my personal opinion, just in my years of researching testosterone and estrogen in the brain. We've got several meta-analyses showing starting on estrogen young in menopause is neuroprotective for all neurologic diseases, Parkinson's, multiple sclerosis, Alzheimer's, non-Alzheimer's dementia. We have data. Nobody's going to go out and say be on hormones for prevention at this point. We have not achieved that yet. And testosterone plays a significant role in the prevention of dementia. We have that data in men. I do not believe that women's brains are that much different.
How early would you say someone should start on hormone therapy?
There's a great paper that just came out on that. Now, there are some thought leaders, because of some studies that are out, saying, why are we waiting for your body to change without why aren't we starting hormones in the end of perimenopause? That's when your biggest rate of bone loss happens. Which is dumb, because you're like, the 2 years before your period end is when you lose the largest rate of bone. And you're like, well, how do you know when your periods are going to end?
That's my thought. How do you know?
Right? You don't know that.
So you don't, but you can start treating patients if they have signs of premenopause or perimenopause. So you don't, because you can't sit here and predict when people are going to go through menopause. But if you have a patient who's 48 years old who comes and says, I have hot flashes, night sweats, foggy brain, fatigue, weight gain, vaginal dryness, painful sex, anxious, you know she's going through it. You don't have to say, well, go back and come here when you haven't had a period for a year. You can actually start treating those patients for hormone replacement. And now we know that people who 20% of the population has the ApoE4 gene for dementia and Alzheimer's, for patients who carry that gene mutation, they actually benefit from 7 years of hormone replacement around the time of menopause. So it doesn't have to be at menopause. You can start it earlier and take advantage of that. And I agree with her. Why wait? It's just like right before this podcast, one of the people who work with us was just telling me she goes to her doctor. She's pre-diabetic and she asks for metformin because of everything we've talked about, insulin resistant. And the doctor says, well, you can take it, but you don't really have to. And she replies to her doctor by saying, so you want me to wait until I'm diabetic to come back and get treated? And that's exactly what's happening in every aspect of healthcare, right? There's no preventative care.
So many women, they're like, they were told by their doctors, you're not sick enough. Come back when you're more sick.
Do you think that women can be on hormones for the rest of their life? So do you imagine having a patient that starts perimenopause on hormones and just has it till they die, that's buried with a patch?
The amount of women who say, you will burn me with this or I will go into the ground with this. That's how much they know the hormones benefit them. Right. And we have safety data. Listen, we've been treating women with hormones for almost 100 years. We've been giving women testosterone for 80 years, right? And I always like this. I'm like, think of a time when 40% of women were on hormones. It's called the 1990s. Yeah. Right? Like we forget that hormones were in the top 5 best-selling drugs in the nation in the 90s. The Women's Health Initiative came, slammed down the curtain, and now at best, we're about 5% of women are on hormones.
What?
That's it. Oh, yeah. So that doesn't include compound, and we know a lot of women get compounded medications, but it is dismal now. I mean, this is a major health disparity issue. Right. Because if you take today and the women who have access to hormones and the education to know not to be afraid of it and how it benefits them, and then you fast forward 10 years, you're going to have major health disparities between those two groups of women. Yeah. And it's at some point, like somebody going 10 years without hormones compared to somebody who's had hormones, their bodies are different.
Yeah.
I want to add 2 things before we end this podcast. Number 1, we talked about vaginal estrogen in breast cancer. Testosterone is okay with patients getting treated for breast cancer. You're so stressed out, you've been diagnosed with cancer, dealt with it, so you can absolutely use testosterone. That's fine. The other thing I want to add is, because I calculate everyone's lifetime risk of breast cancer in my office, and that's my passion in life, and I want every woman to know her lifetime risk of breast cancer. By the way, you can go on shemd.com and figure out your lifetime risk. But sometimes I have these patients who have a lifetime risk of 40%, 50%, 38%, pretty high, and they're scared to not only go on hormone replacement, we can put them on anti-estrogens to reduce that risk. But if these patients are around menopause or premenopause and they're suffering from the menopausal symptoms, sometimes, and I'm not saying always, sometimes for patients at very high risk for breast cancer, I recommend doing a double mastectomy. Like if you have a gene mutation, you're at 50%, do your double mastectomy, do your reconstructive surgery, and then I will put you on hormone replacement. So not only you don't have to take the tamoxifen to reduce your risk of breast cancer, but I can actually give you hormones. But I would prefer for you to remove your breast if your lifetime risk of breast cancer is that high, requiring an anti-estrogen treatment. I just wanted to add that.
Thank you.
Well, I just want to thank you. I mean, honestly, first of all, that You Are Not Broken. There couldn't be a better title for a podcast for women. You're amazing. Well, Dr. Casperson, how can everyone find you? So they can go to You Are Not Broken, and I know you've got this incredible Instagram. You have so much information. It's also so fun to watch, and you're so fun. And,
I'm feisty on it.
You are so feisty on it. So what's your Instagram?
Yeah, Kelly Casperson MD is my Instagram. That's the website too, kellycaspersonmd.com. The podcast and the book are called You Are Not Broken.
Okay, thank you so much.
Thank you so much.
We really appreciate you.
Thanks for having me.
Thanks so much for joining us today on SheMD.
If you want to own your own health, a good place to start is by following us on social media at SheMD Podcast and by subscribing to our show on YouTube or wherever you get your podcasts.
For takeaways from today's episode, visit our website, shemdpodcast.com. We'll see you next time on SheMD. This podcast is for educational and entertainment purposes only. It is not intended as a substitute for a physician's medical advice. You should regularly consult your medical provider in matters relating to your own health. Even though we share our honest beliefs on SheMD, some of the products and services we discuss may involve sponsorships or paid advertising.